he will be talking on ciliopathy with his own cases. Please go ahead.
Thank you so much, sir. Good evening, everyone. So, after exhaustive lecture by Dr.D'Pankar Banerji, sir, I am going to discuss about few short cases of mine that I encountered in my clinical practice. So, let's discuss about the first case. The patient is married non-consanguinously and she has bad obstetric history. The first two scans were not done by me, they were done outside, but I have the report, she has the report. So the first pregnancy was terminated at 8 months, which was reported to be the enlarged fetal head with dilatation of both lateral ventricles with oligohydramnios and with possibility of obstructive hydrocephalus. So they reported it as query-aqueductal stenosis. The second pregnancy was medically terminated at 23 weeks because the ultrasound showed that there was anhydramnios. There was cystic dilatation of fourth ventricle extending up to the cisterna magna with suspicion of Vermean hypoplasia, which suggests possibility of Dandy-Walker malformation. So there were back-to-back 2 pregnancies with brain malformation that was sure. So patient came to me for with her third pregnancy, and that was monochorionic diamniotic twin pregnancy. So a patient came to me for anti-scan and I did the transabdominal ultrasound, in which I found the occipital encephalocele in both the fetuses, in fetus A as well as in fetus B. And while taking the abdominal circumference, I was little bit suspicious about these cystic spaces. I was not sure what it was, but there was something. So I performed the transvaginal scan. So in transvaginal scan, the occipital encephalocele was seen. The kidneys were enlarged echogenic, showing tiny cystic spaces within, and these were seen in abdominal scan as these enlarged kidneys. So there was definitely enlarged, bilaterally enlarged echogenic kidneys, occipital encephalocele. Also, I found these 6 fingers because I found the echogenic kidneys and occipital encephalocele. So I was looking for hand as well. So there were post-axial polydactyly. This is the thumb and this is the finger which I encountered, that is post-axial polydactyly. Also there was suspicion, but I am not sure about this finding. The brain stem of that fetus is not straight, it is jet-shaped. So there was suspicion of tubulinoparhy as well for this fetus, but it was not found later on. But for fetus B, there was occipital encephalocele. Similar findings were there in both the fetuses, enlarged echogenic kidneys and 6 fingers in the fetus B also. Here you can see the occipital encephalocele. So the findings for occipital encephalocele in both the fetuses, bilateral enlarged echogenic kidneys in both the fetuses, post-axial polydactyly in both the fetuses at 12 week 4 days, and so I suspected it to be have the ciliopathy, and I wrote it as the Meckel-Gruber syndrome likely because it completes the triad of Meckel-Gruber. Meckel-Gruber has occipital encephalocele, polydactyly and enlarged echogenic kidneys. So I advise her the chorionic sampling, but the patient, because she knows that a child is not going to survive much, so she opted for termination of pregnancy. So we sent the spot sample for whole clinical exome sequencing. That came out to be positive for 2 variants, that is TMEM67 and SMG9 gene. The TMEM gene shows the frame shift mutation at 1, where the glycine was where the base pair is deleted, and because of that the glycine was replaced with cysteine in the protein. So it is definitely a gene associated with ciliopathy, TMEM67 gene, and it can cause various types of syndromes related to ciliopathies like Rhines-Coase, Joubert, Meckel-Gruber and nephronophthisis. However, there was a glitch because the patient, their gene came out to be heterozygous. That is, one pair was affected, one pair was not affected. So the possibility, because the phenotype is matching with the ciliopathy, so the possibility is that the other gene was possibly deleted, that cannot be detected with clinical exome sequencing at that time, or The other possibility may be that gene is non-functional. So the defective gene will show its phenotype. The other gene, that is SMG9 gene, it is also heterozygous, and it shows the splice site mutation. Splice site mutation means the region between the intron and exon is deleted. That is splice site mutation, and because of that there may be certain syndromes mostly related to heart and brain. So but at that time and this mother had already 2 children, 2 previous pregnancies with abnormal brain malformation, so maybe that gene is responsible for that, but it is also heterozygous, so we don't know whether the other gene is deleted or non-functional. So that was the first case. And for the second case, again the patient is non-consanguineously married. She is primigravida and she has no family history of genetic diseases as given by her. So she
Interrupting you, in previous case, if it is getting the heterozygous state, then it will be very difficult to do the genetic counseling and prenatal diagnosis for the next baby.
Yes, actually for this case the parents should also be tested now.
Yes.
For this variant, if the one of the parents or both of the parents they found to have this gene, then it is proven that the mutation is from the parents only.
2 parents only.
Yes, and about other gene, definitely other tests should be performed, but we don't have for other tests because it was the pregnancy was terminated and the cord sample was sent. So the sample was not there to perform.
DNA was not preserved also.
No, yes, DNA.
Fetal loss also, or
Yes,
neonatal loss.
Neonatal loss. There were previous loss. There are 2 pregnancies which have brain malformations previously. One suspected was aqueductal stenosis and other one was dendivocal malformation.
But they might be related with this ciliopathy also.
They might be related with SMG9. SMG9 is not ciliopathy, but they have heart brain malformation, severe heart brain malformation. So they might be affected with this because we found 2 variants in the fetus.
But it is very difficult to explain if heterozygous state the baby is affected. Things are little bit more
but
complex.
phenotype is matching. Phenotype is matching then with the genotype. So other and all 3 are affected. So definitely something is there.
नहीं, मैं क्या करता हूँ, when I have this, we talk to the lab also why it is happening. So because they have to explain this.
They said that to go for functional analysis of the gene. Functional analysis is quite costly and the patient is not affording. She denied that because I already counseled the patient for that. She was not ready to do that.
No, if patient is ready, then functional, the area of both the parents, there should be a Sanger sequencing of the particular part, so that you can make out the mutation whether they are having carriers or not. Otherwise, if she is having previous fetal losses or neonatal losses.
Definitely testing of parents and followed by genetic counseling of both the parents is necessary actually.
Otherwise, they might have 25% chance again.
Yeah, definitely. Yeah. And it is non-consanguineous marriage, so non-consanguineous. So mostly it is only the one parent which is having, which should be the carrier.
Because heterozygous state in both the genes will not create a phenotype until unless there are both
are involved or other is deleted.
Either might be a compound heterozygote or there must be some mutation in the same allele. Different allele in the same loci.
Same, yes. So for second case, she is also non-consanguineously married and she is primigravida and there was no family history. She came to me for the target scan as 21 week 4 days, where I found the polydactyly of both the hands and both the feet, and there was enlarged echogenic kidneys with mild fetal pylectasis. This is also polydactyly, that is post-axial polydactyly. The heart and brain was absolutely normal for the fetus. So there was bilateral enlarged echogenic kidney showing cystic spaces with post-axial polydactyly of all 4 limbs. So definitely this possibility of ciliopathy was suspected. So I wrote it as the ciliopathy like Meckel-Gruber syndrome and Bardet-Biedl syndrome for this fetus, and further evaluation with amniocentesis for whole exome sequencing and microarray both, because I rule out the deletion as well that microarray can detect. So both the tests were performed, and the result was the BBS9 gene was affected, and it was a homozygous variant,
Yes.
BBS9. So that was quite matching. That is the Bardet-Biedl syndrome with the genotype and phenotype both were matching. However, the glitch was that this mutation, this mutation at 482 location, that is the thymine is replaced with guanine, leading to the change in amino acid sequence of protein, that is leucine is replaced by arginine, causing the whole change in the protein. But this kind of mutation is not seen previously, and it is the first of its kind mutation in the BBS9 gene. Therefore, they report it as the variant of uncertain significance. But since the genotype and phenotype both are matching, so therefore they were counseled and the pregnancy was terminated because of the burden.
And your report might be input for them as it is a significant thing.
Significant thing, yes, that's so. And further, parents were also suggested to go for testing, but right now I don't have reports of parents. So these are my two cases.
So whenever you do this type of cases of ultrasound, so what you were telling that to know the RASopathy and the Ciliopathy or Tubulinoparhy, how do you, when you see the fetus, what is your main goal to do an ultrasound? And
whenever you look for ciliopathies, look for kidneys and polydactyly. Kidneys and polydactyly are very much important for ciliopathies because most of the ciliopathies will present with enlarged echogenic kidneys, and we have an algorithm for enlarged echogenic kidneys. Like if they are isolated only enlarged echogenic kidney, first look at the Leica. If the Leica is low, very low, that is going towards oligo or anhydromnios, then the possibility of rather than ciliopathy, it is ARPKD, autosomal recessive polycystic kidney. If the Leica is normal, that is kidneys are functioning absolutely normal, look for parent's kidney. If parents are having cystic spaces, it is autosomal dominant. Now comes the ciliopathy. Look for polydactyly. Look for brain malformation like Joubert syndrome. You have molar tooth appearance in upper limb or cardiac malformations. There are triads also. Like Meckel-Gruber has triad with occipital encephalocele. So you will think about Meckel-Gruber. There are other things also like Beckwith-Wiedemann syndrome with enlarged echogenic kidneys. They have omphalocele. So with omphalocele and large echogenic kidney, think about Beckwith-Wiedemann. Single umbilical artery, echogenic focus, cardiac abdomen. So that's how I proceed with ciliopathies and other syndromes associated with that. And for RASopathies, pleural effusion you will see, but you will notice there is some effusion, there is some ascites, you don't know the cause. Think about RASopathy. There will be no cardiac anomaly, because if the pleural effusion or ascites or hydropsy is developing, then there may be cardiac defect also. There may be some fetal anemia or RH isoimmunization. So if you have ruled out everything, then think about RASopathy, unexplained fluid. And for Tubulinoparhy, that brain malformations are most important, and the most important structures like falx and brainstem, they will be abnormal in Tubulinoparhies.
central structures will be deviated or?
They will be deviated, they will be crooked, like falx should be central, so it will be like irregular falx. So you don't notice irregular falx routinely, or bulging of falx towards one side, or a small one hemisphere, large one other hemisphere, or unexplained ventriculomegaly, or fissures like Sylvian fissure. The fissure should be perpendicular at 25 weeks.
Yes.
So it will not be that, it will be showing obtuse angle.
Obtuse angle.
So then think about Tubulinoparhy at that time.
So whenever you do mid-trimester ultrasound like 22 weeks, so we have to have this thing in our mind when we do targeted scanning, then if any defect is there, then we have to correlate with this type of syndromic appearance also.
Yes, definitely. We should, and we should look for things like we should know that if we are finding this finding, we should look for hand, we should look for ear, we should look for nose at that time. Then only we can suspect.
Because these are very important. It is not the ultrasound what you are doing. It is the ultrasound with feature plus the future baby of their future pregnancies also.
Yeah.
What help a sonologist or a geneticist or a radiologist can give them to their parents as a counseling, that whether they have this
If it has the genetic association, definitely there are chances, because these are autosomal recessive, to 25% chances are there too in the next pregnancy. We can counsel accordingly for next pregnancy also.
Thank you.
Thank you.
Devashish, thank you very much. And thanks a lot for coming to this journal club. A lot of people are watching us, and I think by listening to him, there is a different way of doing mid-trimester scanning, and think about and think out of box, because ISO guidelines and all, everything is given in a manner that you see this, you see the abnormality. But whenever we see the abnormality, think about the syndromic appearance, so that there will be more help to the parents.
Yes.
Thank you very much.
Thank you.
Bye-bye.